Hello everyone, welcome to our module on brain tumors. So the easiest way to remember all the different brain tumors is to remember them separately for those that occur in adults versus those that occur in children. And I've listed here the tumors that occur in both adults and children in order of frequency. So in adults, the most common tumor is the glioblastoma, followed by meningiomas, schwannomas, oligodendromas, and then pituitary adenomas. And most adult tumors occur above the tentorium. They're called supratentorial. In children, the most common tumor is the astrocytoma, followed by the medulloblastoma, the ependymoma, the hemangioblastoma, and finally the craniopharyngioma. And most tumors in children occur below the tentorium. They're called infratentorial. Most of them are actually in the posterior fossa near the cerebellum. Half of brain tumors are primary brain tumors and the other half are secondary. So the secondary ones are metastases from other organs. And the way you can recognize these is that they're usually multiple lesions seen on brain scans. And the most common sites to send mets to the brain are the lung, the breast, and the kidneys. So what symptoms do patients develop when they get a brain tumor? Well, one of the most common is a headache, and this is why the workup of headache is challenging, because you don't want to miss a brain tumor, even though most patients with a headache do not have a brain tumor. Sometimes patients with brain tumors develop seizures, and then other times they develop motor and sensory symptoms. And when you do brainstem and spinal cord problems, one of the things that causes all those lesions you learn about are tumors of the central nervous system. All brain tumors are treated with some combination of surgery, radiation, or chemotherapy. Some are easily resectable and respond nicely to surgery alone. Others require surgery followed by chemo and radiation. That's why we spend a lot of time trying to understand the clinical characteristics and pathology of each tumor so we can decide how to treat it. So we'll start with the adult brain tumors. Glioblastoma is the most common primary brain tumor in adults. It occurs in the cerebral cortex. It's rapidly progressive and malignant, and it's usually fatal within a year. Some of you may know that Ted Kennedy, the senator from Massachusetts, the brother of former President John Kennedy, had a seizure, and then he was found to have one of these tumors, and he was dead within about 6 months. Half of patients are over 65 years old, and the older you are when you find out you have this tumor, the worse the prognosis. These tumors sometimes cross the corpus callosum and occur on either side of the brain, and when they do, they're called a butterfly glioma. So if you look at this cross section of the brain on the right, the tumor will invade both sides like this, and it will look like a butterfly protruding out from the middle of the brain. They express a protein called GFAP, which is glial fibrillary acidic protein, and this is one of the ways you can identify that the tumor is a glioblastoma. On the right is an MRI picture of a patient with a glioblastoma, and you can see that the tumor is invading the cerebral cortex. Over on the left side is a pathology specimen of a glioblastoma, and it's high yield to know that they do something called pseudopalisading. So what is that? Well, first let's talk about what palisades are. So in forts on the American frontier, people would build these fences of tall stakes, and they called those palisades. So early on, when people were studying tumors, they began to notice that some of them had nuclei that lined up next to each other and looked just like palisades, and so they called that palisading. And if you look at this path specimen here, you can see the nuclei are lining up in palisades. The difference between pseudopalisading and palisading is that in pseudopalisading, the nuclei are lining up because they're being pushed out from something in the middle, in this case necrosis. So therefore it's called pseudopalisading. True palisading is something that occurs in schwannomas, where the nuclei actually just like to line up on their own right next to each other. So you need to know for your boards that glioblastomas exhibit pseudopalisading, and that's where the nuclei of the tumor cells line up like stakes in the ground along a central edge of necrosis. And this slide shows another example of a glioblastoma. There's a big area of central necrosis here, and it's pushing all the nuclei out to the side, creating that pseudopalisading effect of the nuclei lining up like stakes in the ground. Next, we'll talk about meningiomas. These are the second most common brain tumor in adults, and they occur on the convexities of the hemispheres, right near the surfaces of the brain. They arise from arachnoid cells, and they're extraaxial, which means that they're external to the brain. These are actually not in the brain tissue itself. Because they're external to the brain, they can attach to the dura and have this tail of thickened dura from the meningioma cells. These are usually benign and don't metastasize, and they're often resectable. They're often asymptomatic, and I have a number of patients I follow for heart conditions who have been found to have a meningioma when a brain scan was done after a fall or some other condition, and it's actually being followed because it's fairly small and not causing symptoms. Sometimes they do and large enough to cause seizures. Classically, they affect women more than men, and this is easy to remember because the tumor expresses estrogen receptors. An important risk factor for developing a meningioma is prior radiation to the head. So many children who have malignancies get radiation to the skull, and then about 20 or so years later, they are at risk for developing a meningioma. And this is a CT scan of a patient with a meningioma, and the characteristics that you need to recognize are that it's on the outside pushing its way in, and you don't see little fingers of growth diving into the cortex because this is extra-axial. One thing they like you to know for your boards is that sometimes these tumors will grow parasagittally, and that means they'll compress this area of the homunculus right here, and this will give leg symptoms similar to an anterior cerebral artery stroke, and this is one of the classic presentations for a meningioma. Under the microscope, meningiomas have cellular material that's pretty evenly distributed, and then they have these little collections of calcium which are called psammoma bodies, and you can see an example of one of those right here. And this is another example of a psammoma body, and I've zoomed in on it to show you what it looks like up close. Next, we'll talk about schwannomas. These are the third most common adult primary brain tumor. Remember that Schwann cells are glial cells, non-neurons of the peripheral nervous system. So these tend to locate more peripherally. They're classically located on cranial nerve 8. And cranial nerve 8 is the vestibulocochlear nerve. So these patients will develop hearing loss and tinnitus and ataxia. They like to form at the cerebellar pontine angle. So this gives symptoms of facial nerve and vestibulocochlear nerve damage when you have a schwannoma here. They're treatable with surgery and radiation, and they stain positive for a protein called S100, which is also a marker of Schwann cells. And here's a couple MRI images of people with schwannomas. This person has one right over here. You can see this white area here, and this person has a tumor right over here at the cerebellopontine angle. Neurofibromatosis is a condition associated with schwannomas, and they love to ask about neurofibromatosis on the board, so make sure you're familiar with it. It's an autosomal dominant disease caused by mutations of the NF1 or NF2 genes, and there are some characteristic physical findings that patients get. First of all, they get these diffuse neurofibromas, which are these little skin tumors all over their body, and if you ever meet someone with neurofibromatosis, you will not forget it because it is striking to see these neurofibromas all over their skin. They also get something called café au lait spots, and there's a picture of one down here. I think of it as a little bit of coffee spilled on their skin. That's kind of what it looks like. And then in their eyes, they have findings called leash nodules, which you can see in this picture down here. They're these little brown spots in the iris of the eyes. There are two types of neurofibromatosis. Type 1 is the most common type, and that's the type that has the café au lait spots and the neurofibromas. Type 2 is associated with bilateral schwannomas. Almost all patients with neurofibromatosis type 2 get bilateral schwannomas, and this usually makes them deaf. They also get meningiomas, and they get other central nervous system tumors. And one easy way to remember this is that type 2 is sometimes called MISME, which is the multiple inherited schwannoma, meningiomas, and ependymoma syndrome. So if you remember it that way, it's easy to remember that type 2 is the type associated with all the CNS tumors. Oligodendrogliomas are very rare. They are slow growing, and they usually occur in the frontal lobe and present with seizures. They're a tumor of the white matter, and that's easy to remember because you know that the oligodendrocytes are what myelinate the axons in the white matter. The pathology is described as having a fried egg appearance. So if you look at this nucleus right here that I'm circling, you see that it's surrounded by a white area, and that sort of looks like the yolk of an egg surrounded by the white egg, and that's why it's said to have a fried egg appearance to the cells. Final adult tumor we'll discuss is the pituitary adenoma, and this is usually a benign tumor that grows in the pituitary gland. Its biggest problem is often its effect on the endocrine system because it can cause increased or decreased secretion of hormones. They most commonly secrete prolactin, so in women that gives symptoms of amenorrhea and galactorrhea, and in men it can cause impotence. They also present with a headache. And then the classic eye finding of a pituitary adenoma is bitemporal hemianopsia, so that's what I've drawn over here. Basically you cannot see in the outer portion of both of your eyes, and the outer portion is near the temples, therefore it's called bitemporal hemianopsia. And I always remember this by thinking of a tumor just pushing those black parts of the visual field out to the side. When they're smaller than 10 millimeters, they're called a microadenoma. When they're bigger than 10 millimeters, they're called a macroadenoma. And the management of micro and macroadenomas is different. And here's a picture of a pituitary adenoma right here, and you can see that it's pushing up on the optic nerve, which is what they've highlighted in this picture over here, and that's why you get those findings of bitemporal hemianopsia. So now we're going to talk about the childhood tumors, and most of these occur in the cerebellum. The most common is the pilocytic astrocytoma, followed by the medulloblastoma and the ependymoma, and then finally we'll discuss a very rare childhood tumor called a craniopharyngioma. A pilocytic astrocytoma is the most common brain tumor found among children. These tumors are low-grade astrocytomas, so they derive from astrocytes. That's why they're called astrocytomas, and they are low-grade, meaning they are usually benign and do not metastasize. They're commonly found in the posterior fossa near the cerebellum, and this means that in children they can present with signs of cerebellar dysfunction like ataxia and loss of balance. They tend to be well circumscribed tumors that are either cystic or solid, and because they are low grade and well circumscribed, they can often be removed surgically, and this will treat the condition. A characteristic finding when you look at these under the microscope is the presence of Rosenthal fibers. If you look at the top right side of the screen here, these long red lines are Rosenthal fibers. These are seen anytime there is gliosis or growth of glial cells, and they can be seen in pilocytic astrocytomas. These tumors also stain positive with GFAP. GFAP is glial fibrillary acidic protein. It's expressed among astrocytes, so it should make sense to you that this would be present in children who have a pilocytic astrocytoma. Medulloblastomas are rare, but they are a highly malignant primary brain tumor, and it usually occurs in children, usually in the cerebellum, so these children will also present with ataxia. And because medulloblastomas like to present in the middle of the cerebellum, they give truncal ataxia. So truncal ataxia is when children can't stand without falling to one side or the other, or they can't even sit up without someone assisting them because they tend to sway and fall over. And it's a type of primitive neuroectodermal tumor, and that means that it arises from the neuroectoderm. And the neuroectoderm is an embryonic structure, so that's an easy way to remember that these are tumors that will occur in children. You can treat these tumors with a combination of surgery, radiation, and chemotherapy, and if you treat it successfully, about 3/4 of children survive to adulthood. The problem is many of them have complications of treatment, so they can have hearing loss and neurocognitive impairment and other chronic neurological conditions as a result of the tumor they had as a child. These tumors can also compress the fourth ventricle and cause non-communicating hydrocephalus. And finally, they can spread to the cerebrospinal fluid. So when this happens, you'll see nodules in the dura of the spinal cord. These are called drop metastases. And these tend to occur in the lower spinal cord, so sometimes they cause a cauda equina syndrome. And these patients will then have back pain and focal neural lesions from the spread to the CSF. The characteristic pathfinding that you need to know for medulloblastoma is called the Homer-Wright rosette. So first off, let's define what a rosette is. So this is a picture from Notre Dame in Paris. It's a picture of the stained glass on the windows. And a rosette is a design that people used throughout the Middle Ages of circular orientation of flowers. Over here on the right, we've got a picture of a medulloblastoma, and you can see that the tumor cells form these circles that are similar to the rosettes in the church. And so these were called rosettes, and they were named after the man who discovered them, Homer Wright, and that's the characteristic finding of a medulloblastoma. Next, we'll talk about ependymomas. So recall that the ependymoma is the epithelium-like lining of the ventricles of the brain. So these tumors are from ependymal cells, and they're found in the brain and the spinal cord. They often occur in the fourth ventricle and cause hydrocephalus. And over here on the right is an MRI image of a patient who has an ependymoma, and you can see this large tumor in the fourth ventricle, and it's compressing the brainstem, and it's going to obstruct the CSF flow and give hydrocephalus. The characteristic pathfinding of an ependymoma is the pseudorosette, and similar to the rosettes in medulloblastoma, these are circular structures, but in this case they're circles of cells surrounding a central core that's a blood vessel. Hemangioblastomas are very rare, slow-growing central nervous system tumors. They're often cerebellar, but also happen in the brainstem and spinal cord. They're well circumscribed and highly vascular. There are two key facts you need to know about hemangioblastomas. The first is that they can produce erythropoietin, and this means they will increase the red blood cell count, and you will get a high crit and polycythemia. The second is that they occur in a very rare autosomal dominant disease called von Hippel-Lindau syndrome. This is a tumor suppressor gene mutation, so you get lots of tumors. One of them that you get is hemangioblastomas of the brain, including the cerebellum and the spine. These patients also get retinal angiomas, renal cell carcinomas, and pheochromocytomas. Craniopharyngiomas are very rare tumors that usually affect children about 10 to 14 years old. They're called suprasellar because they occur above the sella turcica, and recall the sella turcica is the depression in the skull where the pituitary gland sits. So these tumors can occur anywhere from the pituitary gland up to the base of the third ventricle. They're benign, so they don't usually harm you from metastases, but the problem is they can compress important structures. So they can give visual field defects, they can interrupt the function of the pituitary gland, causing hormonal imbalance, and they can cause behavioral changes if they affect the frontal lobe. It's high yield to know that they derive from remnants of Rathke's pouch. So what is Rathke's pouch? It's an invagination of the ectoderm that occurs in the developing embryo, and it protrudes from the roof of the mouth and it goes on to form the pituitary gland. And that's part of how you can remember that these occur in the area of the pituitary gland. These are often calcified and also full of cysts. They contain epithelial cells, and their appearance can be similar to the pulp of developing teeth. So if you hear about a tumor described that has elements in it that look like teeth, they're probably talking about a craniopharyngioma. And when it compresses the optic chiasm, you get that bitemporal hemianopsia that I talked about before, with absence of visual information coming from the outside of both eyes. And here on the left is an MRI image of a big craniopharyngioma, and then over on the right you've got another one in the middle, and you can see that there's a lot of white, and that is the calcium material inside the craniopharyngioma. Finally, let me talk about pineal tumors, which are tumors of the pineal gland. These are very rare germ cell tumors or parenchymal tumors. And the only thing you need to know about these is that they can compress the pretectal area of the midbrain and give a lesion like what I've drawn over here. And when you get compression of this area of the midbrain, you get something called Paranode syndrome. So the pretectal area is what coordinates your upward gaze. So patients who have a lesion in this area of the midbrain cannot look up. They also have a pseudo Argyll-Robertson pupil. So what is that? An Argyll-Robertson pupil is a finding in neurosyphilis where the eye does not react to light. In other words, it doesn't constrict when you shine light in it, but it does constrict when you have the patient follow your finger into their nose to test accommodation. Generally, an Argyll-Robertson pupil means neurosyphilis, but the one exception is Paranode syndrome. Also, because these tumors grow right near the cerebral aqueduct, which I'm circling over here on this picture on the right, they can compress that aqueduct and obstruct CSF flow. This will give you hydrocephalus and papilledema. So the thing to remember about pineal tumors is that they cause Paranode syndrome and hydrocephalus. And that concludes our module on brain tumors.